When we discuss about treatment, we say we are off-label. What do you think about this off-label in pregnancy, and how would you handle it?
So yes, this was one of the problems actually we had while communicating, while doing this recommendation, this Swiss recommendation. So when you speak about pregnancy or lactation, you are always off-label. So there is maybe 3 or 4 drugs where you will use them not off-label. And so this is a big difference to how you see off-label in how you are using drugs, right? And off-label means that that you can use them, that you need to communicate why you are not doing what the industry asks you to do with their drug. But it doesn't mean that you cannot use them like that. And there are actually very nice recommendations how to do that. And of course, off-label is very useful when you need to cover medical need that is unmet using a drug with how the industry wants it to use. So there is population like pregnant women where it's needed actually. You need to use off-label treatment.
I don't know, do you want to add something?
Thank you, yes, I agree. And from obstetrician's point of view, we are used to use drugs off-label in pregnancy a lot. So we have basically 2 principles in the practical use. One is that there is no similar alternative or alternative drug which is approved for the indication which has the same efficacy profile. And the other point is also that we always want to have an informed consent from the patients. So we inform patients about the fact that the drug is off-label in pregnancy, and this is also documented. I think that's 2 important points. But otherwise, as I said, we are used to use these drugs off-label, and I think it's extremely important also for pregnant women that they are, because many of those, as you know, are excluded from clinical trials because they are pregnant, that they are not also excluded in the basic benefits of drugs.
Do you want to add something? Or?
Maybe just very quickly, I think I agree with you both. The major issue that we had when drafting this thing was not scientifically, not at all. It was because this is something which we want to be backed by the societies, the MS Society, the SNG, and also the gynecology societies. There were legal aspects, right? And so we had it also with the lawyer, and the end discussions were the most difficult with him. So the point we're trying to make, why do we still go on with this? This is really to try to make your situation easier, right? So that you do have some recommendations which you can refer to and which you can then handle in case of whatever. However, I think one basic recommendation of us would really be, in case of a difficult decision or situation, get in touch with a center nearby. It doesn't have to be a university center or whatever, but I think you should be able to refer to knowledgeable people from different fields. I think that is the bottom line, really scientifically. No.
I think nearly everything has already been said. Maybe I emphasize again that it is, if we prescribe it, it is still in the responsibility of the prescribing physician, that he is informed and that he informs the patient in the right way, as you already heard for informed consent.
I think then you have a question.
I think I have the headset, yeah. When drafting, I stumbled over your contribution, because what we always say in general clinics would be, don't worry about your pregnancy. I mean, those minimally disabled patients, we generally, as a simple neurologist, I don't think they are in danger with the pregnancy and the delivery. But then you wrote they are at higher risk or even high risk. And I think we negotiated that term, but what is your, are they really at high risk?
I think there are several aspects of this. One aspect is the patient with an MS itself without a treatment and without an activity. For those women, it has been shown that there is an increased risk of preterm birth. So basically, that's one of the, let's say, most important and also relevant complication, and that certainly itself puts the women at higher risk than a woman without MS. In addition, when the women does have activity, does have DMT treatment, etc., there comes in the aspect of the medication. As you have shown also previously in your talks, there are certain risks with certain medications. So there are new, more novel drugs where we do not have that much experience, how they can influence the course of pregnancy. And this does not only concern teratogenicity, it also concerns other issues of the placental function and placental metabolism. And so basically these are aspects which we need to take into account when we follow up the women. However, if you take the overall picture, the risks still are in the rather low range. So I think it's absolutely appropriate to encourage women to undergo pregnancy and to go through the pregnancy, and the risk, even if they are elevated, they are not a really high risk situations if you compare with other diseases such as systemic lupus or something else.
And what does it mean for management? Can we send them to any gynecologist and obstetrician, or is it really specialized?
This is a political question.
This is why I'm asking you.
But because I know that there, or I suppose that there are not many obstetricians in here, I would say I would rather have the tendency that they're at least in part managed together with an experienced specialist in fetal-maternal medicine, which we do often, that pregnant women are followed both on the peripheral gynecologists together with us, and so that's probably a good model to take care of them.
Do we have any questions in the audience? Yes, Claire.
Yeah, thank you very much for this very interesting discussion. I have a question. So on what did you base your recommendations? Did you base them on pregnancy registries? Because there is such data. And if so, how did you access this data? Because there are also a lot of registries that are held by pharmas. And in my experience, it's not very easy to access this data, but it's very interesting data. And yeah.
I think this is your turn.
So we tried to collect as much data as possible. We also contacted the pharma to see if they give us the data they have. In the end, we got mainly the data which was published, and we tried to summarize all the data as already the other recommendations did, so in a very similar way. And then I think there are some medications which we don't have enough evidence to make a clear recommendation, and there it was important that we come together and form an opinion together, and then there are some recommendations which are also more based on sense and rationale than on the clinical data we have.
But I think it's raising a very important question. I think we should have better MS registries for pregnancies, and each pharma company is doing its own, and then we don't always give the information. I mean, we discussed how difficult it was for the fingolimod registry with Novartis, because people don't report, and sometimes it's very long and time-consuming to include this patient in those registries. So maybe, I don't know, from the pharmacologist or the gynecologist, obstetrician, what is your thought about, are we just in MS not very good to have centralized registries?
No, I think this is a more global problem, so it's not a neurologist or, neurologist diseases problem. So there was this thalidomide tragedy, and since then all pregnant women were excluded from clinical trials that are necessary to have the drugs on the market. And so yes, it's very difficult to get the data that we need to assess the safety of a drug in pregnancy. But there are data out there, and this is also what we saw when we were doing this recommendation. What the compendium does is not going after what is available when it comes to evidence. But we have, there are data, and more we are using health insurance databases. For example, in North America, there are this very nice birth registry in the north of Europe. But of course, having more data would be nice. And I was asking myself, discussing also with you, Caroline, if we would not do something better in Switzerland, actually, like looking at the real registry, because also what we would like to see is how are the kids doing, and not just at birth, but on the long term. And this needs this kind of method, so a registry method, of course.
Would you like to add something?
Yeah, maybe I just may add that there is, before pandemia came, there was an initiative of the Federal Office of Public Health, together also with a specialist of theranogenetic service in Lausanne and in Zurich, etc., where we sat together and thought about building up a registry which has similarly been built up for pediatric drug treatment, which is working well. And we still hope that FOPH will take up this initiative again, and eventually that we can build this up in Switzerland, a registry for these women. And I think MS is one of the extremely important examples where we need this data.
I think there was one other question.
Yes, I actually have two questions rather referring to the talk given before to Mrs. Poe. So the first thing was you said that with natalizumab it's actually safe giving it until the 34th week, I think. But there was data published a few weeks ago where it said that more than 20% of the infants were small for gestational age. So would you say that this happens in the last 6 weeks of the pregnancy, that they're rather small, or because now we actually have in our center we're a bit hesitative continuing natalizumab with pregnant women or planning a pregnancy. And then I have a second question also regarding your talk. When you said you had one case where you gave I think a young girl as well, cladribine, and I was wondering, if there are such a high number of unplanned pregnancies in Switzerland, would you recommend at all to give medications such as cladribine, where it's absolutely like a no-go in the first 6 months to get pregnant?
No, I think for the second question, it's true. Maybe the first one, it was the same girl, right, that we gave fingolimod. But I think when we started Mavenclad, we really discussed this much more in details, probably because the first one we didn't plan it as much. So then you really, of course, you need to trust the person, and she really needs to be careful and not to become pregnant. That would be you're entirely right. I mean, that's a nice way of having induction therapies, that you are safe to have pregnancy afterwards, but you really have to trust the person that she doesn't get pregnant during that time. And if you look at the guidelines, she should even have a double contraception, so it should be mechanical and, for example, the pill. So I think if you really discuss this, and probably it's also important then to inform really well and to document, and then to have this discussion with the patient. But I don't know if you want to...
No, I think that's a very important point. And I mean, our view is, of course, there is 30 to 50% of unplanned pregnancy in Switzerland. But if you take the women with MS, this number is, of course, much more lower. And I think this is also thanks to the good work of neurologists in practice. That's what we see, that women with MS, they are really extremely aware of these issues. And they are much more adherent to the recommendations regarding contraception, regarding family planning, etc. I don't have any numbers about this, but I would estimate from my experience that it's well below even 10% of unplanned pregnancies happening in women with MS. And from that point of view, I do think that there is also good arguments to really go ahead with drugs like cladribine, if this is indicated, if there is a good complaint in a patient. I think that's another point of view of what I think is important.
And for the question, I don't know, do you want to answer? Because I know...
The first question.
Yes, about the low birth rate.
Regards to the first question, I think if we talk about stopping or continuing natalizumab during pregnancy, maybe there is this small increase for a smaller gestational age, but if we think about the rebound risk we're getting when we stop natalizumab, which is around 60%, even if we continue natalizumab in the first trimester, I think the damage we're doing to to the mother and to the child is much higher if we stop the natalizumab and she's getting a severe rebound relapse, which, as we know, can go as high as EDSS 8.5. So I think there are some risks, especially if you treat after the 30th week, where you can get the hematologic abnormalities as well. But at least for them, we know that until now all have resolved in the few months after delivery. But if you look at benefit risk, I think the benefit is higher in continuing the treatment.
And sorry, just one more thing. But the best option eventually would be when the woman is planning a pregnancy and she's taking natalizumab to stop and to switch to like some CD20 depletion therapy, and then continue that eventually during the pregnancy, and one could go back after the pregnancy again if wished.
Yeah, that would be my preferable option as well. Also, we have to think about it. Then we need a bit more time, right? Because with natalizumab, she could get pregnant right away. And if we treat with, for example, anti-CD20, we would maybe want to treat more than just with one cycle. But yeah, that would be my preferable option.
Can I ask one more question? Maybe I'll leave to Alice, because for me, I think it's too early to say we don't give this monoclonal Tysabri anymore for women who wish to have pregnancies, because you really have to balance the benefits and the risk, and I think the benefit of having natalizumab is so high that this risk, for me, is low. But maybe we can have Alice comment on monoclonals.
So maybe one thing that should be said about this monoclonal in general, because now we have so many of them on the market that are treating a lot of indication, is that they have something that is very good for pregnancy, actually. It's that they are not going through the placenta during the first trimester. They are not expected to go through it during the first trimester, meaning that they cannot have teratogenic effects. It doesn't mean that they cannot have phototoxic effects, but at least this is something we can almost rule out, which made them very nice candidate actually for pregnancy. Then of course, what we have to think all the time is about risks for the baby, of course, but also risk for the mother. What is going to happen if you are not treating them. And this part of the equation is very often forgotten because of the fear of harming the baby when it comes to decide if you want to treat or not. But I would not be so afraid about this first study showing small gestational age. I haven't read it, so I cannot be very critical about it. But you know, small gestational age, weight for gestational age, it can be something so little, or is it, you know, the margin of impact? Sometimes they show, because they have a lot of data, they show something that is very, very small. And of course, we are speaking about patients that have a chronic disease, so they have higher risk pregnancy. This is also what Daniel said, right?
Yeah, I agree. And if we look at this balance between benefit and risk, we have to take into account that it's a huge difference if it's about a severe teratogenicity or it's about a SGA, small for gestational age, which is usually obstetrically manageable well. So usually these babies come, have a small birth weight to start with. However, they will be healthy in the long term. The important point is here that the management in pregnancy is appropriate. But if this is secured, I would say the balance is much more in favor of using this drug if there is the maternal benefit there.
I think we have the last question.
Just one remark on the outcome parameter on the birth weight. Given that this cohort was a predominant German cohort, there is a certain there's some bias in it. We had this in the German cohort. There was this initial signal from global that interferon betas may also affect the birth weight. And then it appeared to be that in the German cohort, even the untreated ones, from MS babies, that they were at risk for lower birth weight. So I think there's a certain unsecureness in kind of the data. But I'm looking at Sandra, who's our neuropediatrician, who may know better about that situation or who may want to say something about that.
That's a tricky question. So, as a pediatrician and child neurologist, so we have several reasons for have babies with SGA, right? And we do not know yet very well the data. Do these babies differ from other babies with SGA because they might be at a certain risk of hypoglycemia after birth, of low temperature, and I think there we are not ready yet to come up with a clear-cut conclusion in both ways. So this is clearly not a reason to say we have to stop to treat women with natalizumab only because of the various reasons that were already mentioned by colleagues in the podium discussion. But maybe we can continue on that topic next year, in 2 years, when the data on the babies, which we are following up then afterwards, and this is across the age span all the time, right, are a bit more conclusive, because we have to come up with conclusions that really hold through really across the age span for the mom, for the baby, and also for the future of these babies, which we have not addressed yet in detail. There are some plans to do this also from the developmental side, but we are not there yet. Yeah.
And did you want to ask a last question? So I think, maybe we'll close up now because we can continue at lunch because we are almost over time.